Good evening, everyone. And on behalf of EIZOC, I welcome you all to this important webinar, which is being conducted by the Ophthalmology Resident Teaching Series, number 38. And the topic today is ocular surface tumors. And we have with us Dr. Swati Kalki Reddy from Hyderabad LVPI as a speaker. The webinar will be moderated by Dr. Shamista Behra. And in the panel, we have Dr. Pammi Roy, Dr. Shahil Agarwal, Dr. Manu Sahni, Dr. Ruma Das, and Dr. Mihir Mishra. And amongst the discussions, we have residents and PG students from most of the colleges of the East and also beyond East. I'm also grateful to Dr. Ajit Babu Manji, the mentor of the program, Dr. BNR Subuddhi sir, the chief coordinator, Dr. Jayanto Barua, who is the president-elect of EIZOC, and the secretary, Dr. Suraj Bhattacharya, and the chairman scientific committee, Dr. Sabyasachi Patnaik. Today we are going to have a great informative interaction. And with these words, I welcome you all again. And it's over to you, Dr. BNR Subuddhi sir, to carry forward the webinar. And before that, there's one more announcement. We have the annual conference of EIZOC on the 29th, 30th of November and 1st of December. All of you are welcome to a very nice place that is Kalimpong in West Bengal, where we are going to have a three-day annual conference. Over to you, Dr. BNR Subuddhi sir.
Thank you, sir. Let me share my screen. It's visible?
Yeah, it's visible, sir.
Okay. So, on behalf of EIZOC ORTS program, I welcome you all once again to our program, Sandy program. And this is 30th in series. Since last 3-4 years, we are doing a lot of series on different topics of ophthalmology. And of course, these last few weeks, we are having oculoplasty faculty. Today, we have got a very renowned speaker, Dr. Swati Kalki Reddy, and she's the consultant oculoplasty LP Hyderabad. And she will be speaking on ocular surface tumors, clinical features. So I'm thankful to the EIZOC President, Dr. Pranab Ranjanji, Dr. Secretary, Dr. Saurabh Bhattacharya, and our CSC, Dr. Sabyasachi Patnaik. Today, I welcome our President-elect, Dr. Jayant Barua. He will be sworn in as the President recently, in the next month, in the Kalimpong conference. So, Dr. Jayant Barua ji, welcome you, because you will be continuing another 2-3 years with us with these programs. Of course, mentor, Dr. Ajit Babu Maji, selecting speakers, selecting time, selecting everything is really superb. So, till date, whichever the speakers we have selected by him, they are wonderful speakers. Sometimes we do not know them, but once you are exposed to these speakers, you could know their potential. So, thank you, Dr. Ajit Babu. I welcome you to this webinar. I am the chief coordinator, and today's speaker, Dr. Swati, and our moderator will introduce her to the audience. I don't want to introduce. Today's moderator being Dr. Shamista Behra. She is the professor, Limsar Medical College, Purla, Odisha. And today's panelist, Dr. Pammi Roy. She is the assistant professor at HOD, JLN Medical College, Bhagalpur. Dr. Shahil Agarwal is a regular with us, the assistant professor at the RP Center, AIMS, New Delhi. Dr. Manu Sahni, assistant professor at PGM at Chandigarh. And Dr. Ruma Das, professor at HOD, Silchar Medical College, Hospital, Assam. And of course, Dr. Mihir Mishra is the consultant, MGM Eye Hospital, Raipur. Is always with us in almost all oculoplasty sessions. I welcome you all to this webinar. And of course, the program is meant for the residents. So today, really, we are fortunate to have 14 residents. I hope they will be active in this webinar. They will ask questions, and they will also answer certain questions asked by our panelists and moderators and also speakers. So Dr. Satta Parbar, JPM Rotary, Cuttack, Dr. Sumaya, JLN Medical College, Bhagalpur, Dr. Ekta Mishra, again JLN Medical College, Bhagalpur, Dr. Subhasri Saw and Dr. Rupali Mishra from MTC Medical College, Bharatpur, from Light Town, Dr. Sarita Raut, RIO SCB, Dr. Surbi Prasad, Silchar Medical College and Hospital. Again, Dr. Krishna Priya also from Silchar Medical College, Assam. Dr. Seal from AIMS Patna, Dr. Sonali Singh from Bhimsar Burla, and Dr. Sunanda again from Bhimsar Burla, Dr. Liju from RIO SCB, Dr. Aparajita Sukla from AIMS Raebareli, and Dr. Ankita Swai from Agrawal Sai Hospital, Cuttack. So today's discussions really were very good number of discussions, and they volunteered to participate in this webinar. I expect them to be present throughout the webinar and listening to the speaker and asking questions to these viewers. I welcome you all and all the viewers joined with us today's webinar. So thank you very much. And it's over to Dr. Ajit Babu say a few words. So over to Dr. Ajit Babu. Are you there? No. I think it's okay. It's over to Dr. Sarmishta, our moderator today. So please continue the webinar.
Thank you, sir. I hope you can see the screen, sir.
Yes.
Thank you. To have Dr. Swati Kalki ma'am with us, we are honored and we are blessed actually. We are blessed. So she, ma'am, is the head of Ocular Oncology Services at the Operation Eyesight Universal Institute of Eye Cancer, L.V. Prasad Eye Institute. And she has more than 300 lectures in various national, international forums, published more than 275 peer-reviewed articles, contributed 30 chapters in oncology textbooks, and is an ocular oncology section editor for 2 international journals. She was recently elected as the co-chair for AAO BCSC Section 4 for 4 years, 2025 to 2030, committee member of AMPC section of ARBO for the years 24 to 27. Ma'am is the recipient of the prestigious Shakuntala Amirchand Prize and Novartis Oration Award from the Indian Council of Medical Research and the IAPB Vision Excellence Award 2020 for her contribution to the field of ocular oncology. And Kalki ma'am, Swati ma'am is the brain behind Vitaton, an annual running event creating awareness about retinoblastoma and raising funds to support the treatment of children from financially distressed families with this deadly eye cancer. Over to you, ma'am, for the session.
Thank you very much. I'll first just share my screen.
Ajit Babu, would you like to say a few words? Dr. Ajit Babu? You're muted. You're muted.
Swati is very good speaker actually. Let us listen to her first. Swati, welcome.
Yeah, if you have, I mean, if you want to address anything, please. Okay. So I hope all of you can see my slide.
Yeah. Yes.
Yeah, so first of all, thank you very much for inviting me to this forum. Thanks to Dr. Ajit Babu, who called me if I could be a part of this forum, and thankfully I could be a part of this. So thank you very much for that. Thank you, Dr. Subudhi, for coordinating about all the small, minute details that had to be coordinated for this webinar with me. And thank you, Dr. Sharmishta, for a very kind introduction. So with that, I will start the topic. So today we will be discussing about ocular surface tumors, and I'm happy that a lot of postgraduates have joined. And please feel free to stop me at any slide that you want to ask any question about, and hopefully we will have an interactive session, and it's just not us staring at the screen and not interacting with each other. So broadly, the conjunctival or the ocular surface tumors, they can be divided as the tumors of the epithelium, melanocytic tumors, vascular tumors, neurogenic tumors, lymphoid tumors, myxoid, and metastatic tumors. I'll be talking to you about the more common tumors that we come across in our Indian practice. So first we'll start off with the benign tumor of the ocular surface, that is the conjunctival papilloma. It's extremely rare to find this papilloma extending onto cornea. Most of the times it is limited to the conjunctiva itself. Now it has a very peculiar vascular pattern, as you can see in the pictures as well. It has these hairpin loop pattern of the vessels which are present within the lesion. And it is a very common benign tumor. Probably most of you would have seen at least a case by now in the OPD. And they're mainly present in the bulbar conjunctiva, as you can see in the above picture, or it can be present in the lower fornix. Of course, it can occur anywhere on the ocular surface, but these are the common sites where the papilloma can occur. It can be sessile or it can be pedunculated. So if you see the above picture, it is a sessile lesion, while the below picture, it has certain thickness to it and we can actually lift it with a bud. So it is a pedunculated lesion. Most commonly, it is associated with HPV virus infection with 6, 11, 16, and 18. In fact, I have a couple of cases, mainly in children. So generally, we have this what we call as conjunctival papillomatosis of childhood, where multiple papillomas are present, mainly in children. And in them, we sometimes advise the parents that the child has to be given the HPV vaccine, so that it will minimize the chances of recurrence in the child. So this is another example of a large conjunctival papilloma. As you can see, again, the typical vascular pattern is seen even in this lesion. First, I will describe the clinical features and then treatment we will discuss towards the end. The next one is the most common ocular surface malignancy that we see. That is the ocular surface squamous neoplasia. In fact, this is the third most common malignant ocular tumor across the world. It's not like, very long back that it was first described. It was described in 1995, though it was described earlier, but the term ocular surface squamous neoplasia was coined in 1995 in Australia by Graham Lee and Lawrence Hurst. And it's an umbrella terminology, and it includes dysplasia, carcinoma in situ, and squamous cell carcinoma. It is more common in males, and probably because of the increased sunlight exposure in males when compared to that of females. And it is more common in the older age group. Of course, it can occur in younger patients, especially if the patient has the systemic condition called the xeroderma pigmentosum, or if the patient is immunosuppressed. That is, if the patient is HIV positive, or if the patient has undergone a renal transplant and is on immunosuppressants, or any cause of immunosuppression, these patients are prone to develop ocular surface squamous neoplasia at a younger age. Now, there are various theories on why this tumor occurs, but the most accepted theory is the limbal stem cell theory, where it is believed that this tumor arises from the limbal stem cell area. And that's why most of the tumors are, the epicenter of most tumors is present at the limbus. The other factors that might play a role is the exposure to ultraviolet B light, or it could be because of viruses like the human papilloma virus and HIV, as I already described, where they are more prone to develop this condition. The various other factors that can also contribute are any localized or systemic immunosuppression. When I say localized immunosuppression, it can occur in eyes which have been treated, which have undergone penetrating keratoplasty, because these patients are put on long-term topical steroids for almost 9 months to 1 year or even longer. And this itself can cause localized immunosuppression and can be an inciting factor for the OSSN. It is also known that it can occur in chronic inflammatory diseases of the ocular surface. Whenever even ocular surface injury can incite it, vitamin A deficiency, exposure to certain chemicals like arsenic, smoking, and even long-term wearing of ocular prosthesis, which causes chronic irritation of the ocular surface, can also incite OSSN. Now, when we talk about OSSN, these are the various features that we look for in the lesion. So this is the leukoplakia, that is where you can see that the entire lesion is just covered with keratin. So this is what we call as leukoplakic lesion. Sometimes it could be that there is a large lesion with areas of keratin. So all those white areas that you're seeing on the lesion is nothing but keratin. Whenever keratin is present on an ocular surface lesion, you should rule out OSSN. They will have, most of the lesions have feeder vessels. As you can see, there are very prominent nasal feeder vessels that are present in this, associated with this tumor. Intrinsic vascularity, as you have seen in conjunctival papilloma, there is also a variant called papillomatous variant of OSSN, which I'll be showing you pictures later as well, that can look very similar to conjunctival papilloma, and the diagnosis can be of, to differentiate between papilloma versus OSSN can be only on histopathology. Now, on fluorescein stain, when you stain a lesion, especially when there is a corneal lesion, it outlines the lesion and you can identify the exact extent of the corneal and the conjunctival lesion. And even the rose Bengal stain, what you may not be able to appreciate with the naked eye, you can appreciate the margins very well when you stain it with rose Bengal stain. Now, as I mentioned earlier, the typical location of OSSN is the limbus, as you can see in all these 4 pictures, where the limbus is involved in all the 4 cases. But we should also remember that OSSN can have atypical locations. Like the first picture, you see that the limbus is clear. The lesion is present only in the bulbar conjunctiva. The second picture, where the lesion is present in the tarsal conjunctiva, which is again a very atypical location for OSSN. Sometimes OSSN can be present purely on the cornea without involvement of the conjunctiva, though it is not, it's not very common, but it does occur in few cases. And sometimes it can have intraocular extension, as you see in the last picture, where there is a mass that is present in the anterior chamber, where there is intraocular extension of OSSN. Now here, these are all examples of corneal OSSN. That means where the lesion is predominantly present on the cornea. So in the first picture, you can see it's very, very subtle. So it's like a tongue-shaped lesion that is present on the cornea, which can be easily missed if a good examination is not done. The second picture, where it shows a ground glass appearance, where the lesion is covering the entire surface of the cornea. The third one, where there is a gelatinous lesion that is present on the cornea. And the fourth one, where there is a placoid portion and there are elevated areas within that placoid portion. So these are various ways how a corneal component of OSSN can present. Now, this is an example of classic how a corneal OSSN looks like. Can any of the postgraduate tell me what are the classic features that you're seeing here of the corneal component of OSSN? Anyone?
Yes, Sonali. Sonali, can you say?
Yes, ma'am.
Can you say, ma'am's? Can you answer ma'am's question?
Yes, ma'am. It is involving the limbus and also a part of cornea.
Yeah, very good.
Vascular feeder vessels.
Okay, there are not exactly feeder vessels. You can see intrinsic vascularity. Feeder vessels would be like, very dilated and tortuous going into the lesion that you don't see in this picture, right? So it has intrinsic vascularity, but not feeder vessels. So what I was trying to ask is you see that it has very classic fimbriated edges. So you see the corneal portion of the lesion. I don't think you can see my cursor, but the corneal portion, you see that very ragged appearance of the margins, right? Like teeth-like appearance of the margin. So that is what we call as fimbriated margins, which is a very classic feature of corneal OSSN. The best way to identify corneal OSSN, what is the technique that we are using here? Anybody? What illumination on slit lamp?
Retro illumination.
Retroillumination.
Retro illumination.
Very good. So retro illumination is the best way to identify the corneal OSSN. So you can see that now the margin is very clear, where the inferior half of the cornea is clear of tumor, while in the superior 1/3, you can see that there is tumor that is present. So retro illumination is the best way for you to identify the corneal component of OSSN. Now, sometimes OSSN can be bilateral in certain systemic conditions like xeroderma pigmentosum, whenever the patient has immunosuppression like a HIV patient, or certain systemic conditions like Papillon-Lefèvre syndrome. Here is an example of a child with xeroderma pigmentosum. So you can see that the child has the skin lesions, right? This child has all the macules that are present, the pigmented lesions that are present on the skin, telling you that this is a case of xeroderma pigmentosum. If you see the first picture, the child has lesion in the right eye. That was treated, and then he came back a few months later with tumor in the left eye. So if you see the left eye, now the tumor, the below picture, the tumor is treated in the right eye, but the left eye has developed the tumor. So xeroderma pigmentosum, every follow-up, it's very important to keenly examine the eyes, because these patients can develop, these lesions may not be at the same time, but consecutively. HIV infection is another, where you can see these are the two eyes of the same patient. The patient first came with a lesion in the right eye, where you can see it is very diffuse lesion covering almost the entire ocular surface. And then that eye we had to exenterate or do the orbital exenteration. And then subsequently he came back a few months later with lesion in the temporal bulbar conjunctiva. So whenever they present with HIV infection, please, examine the eyes properly, because one eye may have very advanced tumor and your concentration will be on that eye, and the other eye may harbor a very, very small tumor which can be easily missed. Now, this is an example of Papillon-Lefèvre syndrome, where you can see that there is scaling of the skin that is present in the hands and the legs. And this patient again had bilateral OSSN. So you can see the lesion is very obvious in the right eye. And in the left eye, after a few months, he developed the lesion in the left eye, which is less subtle when compared to that of the right eye lesion. Now, there are various morphological types of OSSN. That is first the gelatinous, which can be leukoplakic or papilliform, nodular, diffuse, pigmented, and nodulo-ulcerative. We'll go one by one what they look like. Now, first the leukoplakic variant. So here is an example of leukoplakic variant where the entire lesion, it just appears white in color. This is leukoplakic variant of OSSN. Papilliform, as I mentioned before, it resembles the conjunctival papilloma in the vascular pattern, and the only way for you to diagnose is by biopsy. Nodular OSSN, where there is like a nodule on the ocular surface, as you see in this picture, with some amount of keratin. Diffuse, where it's like, the entire ocular surface is just like, it has this thin layer of tumor that is present, spread across the ocular surface, like here. Pigmented, now pigmented variant of OSSN is pretty common in the Indian population, because we are a pigmented race. And we tend to have higher incidence of pigmented OSSN when compared to that of the West. The other variant which is commonly missed is the nodulo-ulcerative variant. So here you will see some areas of thickening of the conjunctiva and some areas of thinning. Like you can see here that in the canthal area there is thickening, while perilimbal areas there is thinning of the conjunctiva and the sclera. And most of the times these are associated with what looks like corneal opacity, but on histopathology, it is actually the spread of the tumor in the stroma. Now, this is something that we had published in 2017, and in fact, we were the first to describe this variant of OSSN. Now, moving from OSSN to pigmented tumors of the conjunctiva, which again is very, very commonly seen in the practice. Now here, this is an example of conjunctival nevus. Now, conjunctival nevus most often is unilateral. It is present in the interpalpebral area. Now, one common misnomer or misconception is that all nevi are pigmented. That's not true. Nevi can be pigmented or non-pigmented as well. They have well-defined margins. They have internal cysts, and they have very low risk of conversion of the tumor to melanoma. So if you see this picture, you can see certain well-defined circular areas which are seen at the border of the lesion. These are nothing but the internal cysts that are present. So this is a closer look of the same picture where you can see the cysts that are present at the margin. And these are few other examples of the conjunctival nevus. These I have just put for you to understand that the first picture here, there is like what looks like a nodular component, but actually it is a large cyst that is present, and this can be well appreciated when you do an OCT through the lesion, that this will be a cystic area. Now, the second picture, it shows amelanotic nevus. Here, the pigmentation is very, very minimal, just at the margins. Most of the lesion is amelanotic. Now, third picture, it shows a combination of pigmented and non-pigmented portion. So you can see that in the center, there is pigmentation, and it is surrounded by the non-pigmented area. And the fourth picture, you can see that it can sometimes extend onto the cornea as well. Now, this is another pigmented lesion, and again, very common in our population, what we call as racial melanosis or complexion-associated melanosis. Now, this, unlike the nevus, it is bilateral, nearly symmetrical, and it is mostly present in the perilimbal area. The third pigmented lesion that can occur on the ocular surface is primary acquired melanosis, or what we popularly call as PAM. So these are mostly unilateral. They are pigmented lesions. They, unlike the conjunctival nevus, they have ill-defined margins. They usually do not have internal cysts. Mostly they're present in the bulbar conjunctiva, but here please note that these lesions have very high risk of transformation into conjunctival melanoma. And that is why we have to periodically examine these lesions whenever a patient presents with PAM. This is very classic conjunctival melanoma. So melanoma, it can arise de novo, that means without any pre-existing lesion. It can rarely arise from a pre-existing conjunctival nevus. More commonly, it can arise from a PAM or primary acquired melanosis. Most of the times it is unilateral. It has well-defined margins. Again, melanoma can be pigmented or it can be non-pigmented. And you should remember that these are very important to identify because they have very high chance of metastasis. That means metastasis can occur in 30% of the cases by 15 years. After the pigmented lesions, then next we will be moving to lymphoid tumors. So do any of the postgraduates have any questions to whatever I have spoken till now? Any questions? If not, I will move forward, but let me know if you have any questions.
Kalki, any high-risk features, clinical features in nevus that can have a conversion to melanoma?
Yeah,
I'm taking their role.
Yeah, thanks, Dr. Ajit Babu, for the question. I think when the nevus, usually the nevus is present, identified mostly in children. And these cases, when you periodically examine, if the nevus, which was previously flat, it becomes more nodular, it develops nodularity, the thickness increases, that's a sign that it is converting into melanoma. So I have cases where the patient has followed up for 5 to 6 years, and then after 7 years or so, it has transformed into melanoma. That though it is rare, it can still occur, and that is why it's not that you simply write off a conjunctival nevus. Okay, this is just a nevus, does not require follow-up. No, that's not correct. Whenever there is a nevus, at least we have to examine them once a year to see if there is any nodularity or if there is any thickening that is occurring in the area of the nevus. And especially when the internal cysts are not there, these are the lesions that have to be keenly observed for transformation into melanoma. I hope that answers the question, Dr. Raju.
Yeah, one question, Dr. Swati. Based on the histopathology, there are a few risk factors which more favors towards the malignant potentials. So, could you elaborate on that part?
Yeah, so of course the nevus based on histopathology, like depending upon where the nevus cells are present, whether they are present in the basal layer of the epithelium, whether they are present at the junction, or whether they are present in the stroma. It can be different ways that it can be classified. Most of the times the junctional nevus, when they are present, as the child ages, these nevus cells, they can they can migrate into the stroma, and they can, it's not that when the nevus is in one layer itself they remain there. The nevus cells can migrate. Usually when they are present within the epithelium or at the junction, they're less likely to transform into malignancy, though as they progress deeper there is higher chances that they can transform into malignancy.
Madam, how do we differentiate nevus from a freckle?
Yeah, so the freckle is nothing but like when it does not have any thickness at a freckle. Generally, it's a interchangeably used word most of the times, but in general, freckle, it doesn't have any thickness to it at all. While nevus will have some amount of thickness to it. It's not like when I say thickness, it doesn't mean like it will have 2 to 3 millimeters of thickness, but it'll still have some, like for example, racial melanosis doesn't have any thickness to it. It is just pigmentation that is present. Similarly, freckle also, it will just be like, small dot of pigment or a small area of 1 millimeter area of pigment that might be present. And they very rarely transform into malignancy.
Thank you, madam.
Please continue.
Okay, so we will continue with the lymphoid tumors, which is another common thing that we see in the clinics. Now, this is an example of what we call as BRLH, that is benign reactive lymphoid hyperplasia. These are pinkish lesions that are present. And if you see very carefully, the overlying conjunctival epithelium will be nice and shiny. It will have a nice shiny covering with the conjunctiva. So, which means that these lesions are present in the conjunctival stroma and not in the conjunctival epithelium. While OSSN is an epithelial tumor, while the lymphoid tumors are the subepithelial tumors. Here is an example of BRLH, or the benign reactive lymphoid hyperplasia, which is present in both eyes. And this is quite commonly seen in children. And most of the times they may have history of that their tonsils enlarge or their adenoids enlarge, because these are all the lymphoid the structures that can enlarge. Similarly, in the eye, you can get the benign reactive lymphoid hyperplasia as well. But it should be differentiated from a malignant counterpart of it, that is conjunctival lymphoma. While BRLH is more common in children and middle-aged patients, conjunctival lymphoma is more common in older individuals. Now, it can be present as an isolated disease, or it can be part of systemic lymphoma. It can be unilateral or it can be bilateral. It can start as an unilateral disease and subsequently become bilateral. And it can also have involvement of the orbit, uvea, or the eyelid as well. The more common sites of these conjunctival lymphoma is that it remains hidden in the fornix. So sometimes the patient may just present to you with a ptosis. And when you lift the eyelid, you'll see that there is a salmon pink patch that is present beneath the eyelid. So the ptosis is just induced because of the lymphoma, the infiltration of the levator palpebrae superioris with the lymphoid tissue. And it has this classic salmon pink color, what we describe, as you can see in the picture as well, that it is very distinctive color that is present. And as I mentioned even before, you can see that the overlying conjunctiva is nice and shiny. because the epithelium is not involved in these cases. It is a subepithelial lesion. Now, as we have talked about diagnosis of few of the common conjunctival or the ocular surface tumors that we see in the clinics, next, let us discuss when do we treat an ocular surface tumors? Do we treat all of them or do we treat only few of them? So first, now this is a vascular tumor that is present on the ocular surface in the fornix. This is just a hemangioma. And this is a picture which is taken few months later where it has spontaneously regressed. We haven't done any treatment to this patient. It has spontaneously regressed. So such lesions, when it is a vascular lesion which is not affecting the vision, it is not, the patient is probably not cosmetically concerned, then you can just let it be. You don't have to treat every lesion. Here is another example. This is, can any postgraduate tell me what is this? What do you think this lesion is? Is it a nevus or a melanoma? What do you think?
Melanoma.
Okay, this is a nevus. This is a nevus which is present in the caruncle. If it were to be melanoma, you would expect some amount of feeder vessels or anything. The surrounding conjunctiva, you see that it is very clean, right? There are no dilated vessels which are feeding into the tumor, nothing. So this is just a nevus. Caruncle nevus is another condition which is pretty common. Now, these lesions, again, if the patient is cosmetically concerned, you go ahead and excise it. But if the patient is not cosmetically concerned, you can observe. So the option of observation or excision, it depends upon what the patient wants. So it's not necessary that you always go ahead and excise these lesions. Now, what do you think this lesion is? Anybody?
Benign melanosis, ma'am.
Yeah, so this again, it is just the complexion associated melanosis, which has gradually increased in size with time. It can, of course, the two, you can consider a differential of even a nevus. It depends upon the age of the patient. If, say, for example, this is a child who's coming, say, is a 6 or 7-year-old child, you would think that you will call this as a nevus itself. But if it is an old patient who's come with this, who gives no history of this lesion prior and has some amount of pigmentation at the limbus, then it can be racial melanosis. Now, when do we treat? Now, treatment, so as we discussed, the benign tumors, there is an option of observation or treatment. But when it is a malignant tumor, you have to definitely treat the lesion. Now, let us see the examples. Now, okay, can anybody tell me what do you think this lesion is? You can see keratin, you can see that it is located at the limbus, you can see that it... Yeah.
OSSN.
OSSN.
Very good. So this is a case of OSSN, right? So you can see keratin, you can see the limbal location of the lesion, extension of the lesion onto the conjunctiva and the cornea. So this is a case of OSSN. Now this was seen by somebody who is novice and did not diagnose this as OSSN, and the patient did not receive any treatment. And this is what the patient came back with. So you can see that the lesion has progressed. Now it has become a nodular lesion with feeder vessels, and you can see the angry looking vessels that are present in the second picture. Now the keratin is much more obvious as the lesion has increased in size. So OSSN, always treat the lesion. You cannot observe OSSN. Okay, so that is one. Now here is another example. Now this is a middle-aged or slightly older lady who presented to the clinic. And this is what she presented with. What do you think this patient has? What is the lesion which is pink in color, which is in the fornix?
Papilloma.
No, papilloma will have the papillary, the different form of vascularity, right?
Lipodermoid.
No, this is a case of lymphoma. Okay, Because we just discussed now, right, that it has salmon pink color. So this is a very subtle case of lymphoma. Okay, so this patient again did not receive treatment, and you can see that the lesion has increased in size with time. And then this is what it has ultimately become, where the lesion has extended deeper into the orbit as well. So the patient who came to us like this, ultimately the lesion increased in size and went on to extend into the orbit. Okay, so this is a classic case of lymphoma. So this is what it had. The patient initially had this and it gradually increased in size. So whenever you see a shiny conjunctiva over it with a salmon pink patch on the ocular surface, please think of lymphoma. Now, when to treat so we have seen what are the lesions that need treatment. Now we will see when do we treat it. So this is what we discussed. So benign lesion you can observe or treat, or malignant lesion you have to always treat it. Then now we will discuss how do we treat a conjunctival tumor. Now this, as I mentioned, this is a case of nevus, right? We discussed this in the previous picture I had shown. This is a large cyst that is present. This is a case of conjunctival nevus. If I have to treat this lesion, you can go ahead and excise it. Now here, when I excise, I don't have to take wide margins. When I say wide margins, generally we take 4 millimeters margin. So if it is a benign lesion, you don't have to take 4 millimeters margin. So I can simply excise it, taking a little 1 to 2 millimeters margin around the lesion and excise it. Now, this is a case with, what do you think this patient has? Very classic. The lesion is flat. It is present near the limbus. It is bilateral. What do you think this lesion can be?
Racial melanosis.
Melanosis.
Very good. This is a case of racial melanosis or complexion-associated melanosis. So this patient, he was, obviously you can see he's a relatively young patient and he developed these lesions and he was very cosmetically concerned. Now, if I go ahead and excise it, you have to excise an extensive area. And it is unnecessary surgery for the patient because it is just going to cause scarring and pseudopterygium and all of it. So this patient, what else do you think can be done? If I don't want to surgically excise, any idea what else can be done? Any try you want to give, anybody? Yeah, I think I heard some whisper there.
Cryotherapy.
Yes, very good. So that's what we did for this patient. We did cryotherapy, and you can see that with cryotherapy, the pigment disappeared. So you can do some non-invasive techniques, like less invasive techniques like cryotherapy for benign conditions like these. But when it comes to malignant tumors, there are various options that are present now, especially for OSSN. So you can either excise it, you can do plaque radiotherapy, you can give topical mitomycin C, interferon alpha 2B, topical 5FU, or sometimes you might have to enucleate the eye or do orbital exenteration. Now, when you see, this is a case of OSSN. So if I have to excise this lesion, you have to do wide excisional biopsy. When I say wide, that means you have to take 4 millimeters margin all around on the conjunctiva and 2 millimeters margin on the corneal side where we do alcohol keratoepitheliectomy. Then after the tumor is removed, you do double freeze thaw cryotherapy. So you all, I will show you, I think I have a video as well, I will show you. And when it is extensive lesion like this, so here you can see that almost half of the ocular surface is covered with the tumor. This patient was not responding to any topical treatment, so we had to do surgery for this patient. And when we do extensive surgery, the patient is going to lose a lot of limbal stem cells as well, right? Because we are dissecting at the limbus. In these patients, we also combine it with simple limbal epithelial transplantation so that the limbal stem cells get replaced. Now I'll show you a video. This is a video, I hope it plays. Yeah. So we are taking 4 millimeters margin around the tumor. Okay, this is a case of OSSN. We are taking 4 millimeters margin. Once we take 4 millimeters, this I'm just marking just for the, so that the margins are clearly marked out before we do. Then I'm applying a bipolar cautery, just so that because these lesions have a lot of vascularity, so you can apply bipolar cautery. Now with monopolar cautery, we are dissecting at the margins. We follow what we call as no touch technique. That means at no point of your surgery, you're going to touch the tumor directly. You hold the normal conjunctiva around the tumor, but not the tumor directly. Now on the corneal side, we are taking 2 millimeters margin. Now, once we are marking the 2 millimeters margin on the corneal side, we apply absolute alcohol. This is 100% alcohol dipped sponge, which is being applied. Now, what this alcohol does is it separates the epithelium from the basement membrane, and then with a crescent, you can just peel off the epithelium. Once you peel off the epithelium, you just dissect it. Now, here again, I'm holding the normal conjunctiva, not the tumor. And then we are dissecting and removing the tumor. The tumor is completely removed. It is laid on a filter paper and sent to pathology lab. We are doing here double freeze-thaw cryotherapy is done to the surgical margin. So this is one round of cryo. We repeat it twice. Now this is, I'm advancing the tenons. How much ever I can advance the tenons, I'm going to advance. Now the fibrin glue is being put. And once that is put, we are going to put the amniotic membrane graft. So that's the amniotic membrane graft that is placed, and we are just trimming it so that it covers the defect. Now in this patient, because there was extensive loss of limbal stem cells, I'm also doing simple limbal epithelial transplantation. So I'm harvesting the limbal stem cells from the opposite eye, and I'm cutting that into bits, the limbal stem cell area, and then just putting it on the amniotic membrane graft. This is called as simple limbal epithelial transplantation. And these are secured in place by glue. Again, we are just putting fibrin glue so that they stay in place. And we put a bandage contact lens. So that completes the surgery. Now, please understand that we do not do SLET or the simple limbal epithelial transplantation in all cases. We do it only when there is extensive loss of limbal stem cells. Now, here is an example where we have excised and we have done SLET, and you can see that the patient, the lesions have healed very well without causing any limbal stem cell deficiency signs. Now, this again, we have published for those of you who want to read more about this technique. This has already been published in American Journal of Ophthalmology. This is another example where we have simply excised. Here, no SLET has been done, just excision has been done, and the tumor is completely removed. Now, when do we do plaque radiotherapy? Here, we have done plaque radiotherapy. Now, this is the ruthenium plaque that we have used. So when we remove the tumor and we, on histopathology, if the surgical base is positive, if the base is positive, then we do plaque radiotherapy. And you can see that that area has nicely healed after plaque radiotherapy. I will take another 10 minutes. I hope I'm not overshooting time.
No, not at all.
Thank you, Dr. Ajit Babu. Okay, then next we'll move on to topical medications for OSSN. Now, topical medications, topical mitomycin C was being used very commonly before, but nowadays we rarely use mitomycin C because we have better alternatives. This is a picture of the times when mitomycin C was being used. Any idea why we do not prefer to use mitomycin C? Any of the postgraduates want to answer?
It causes complications, fibrosis.
Yeah, very good. So because mitomycin C causes a lot of complications, like it can cause limbal stem cell deficiency, it can cause punctal stenosis, it can cause the corneal, irregularity, all of it. It has a lot of long-term complications. That's why we do not prefer to use mitomycin C. The times when we used to use it, generally we used to use at a concentration of 0.04%, and we used to always give a on and off period because it's a very toxic drug to the ocular surface. The popular drug that was used was after mitomycin C was the interferon alpha 2B, where we use, if it is used as topical medication, it is used in the concentration of 1 million international units per cc. And if we are injecting, then we use 5 million international units per cc. If it is, at least the protocol that I used to follow is, if it is plain corneal lesion, I used to give only topical medication. If it was a conjunctival component also was there, I used to combine topical medication and perilesional injection. Now, here is an example where we are injecting. So what we do is we lift the conjunctiva. So select an area where there is no tumor. So you don't want to be passing the needle through the tumor. You select an area where there is no tumor and then inject and balloon the conjunctiva in the area of tumor. Here are few examples after the use of interferon alpha 2b. So you see that there are all these 4 lesions have extensive ocular surface squamous neoplasia. We have given injection and topical interferon alpha 2b and see how nicely they have transformed after treatment, where the lesions have completely disappeared. Now, it can be used just as topical medication for corneal lesions. So the second panel, you see the corneal lesions are outlined so that you understand what we are trying to treat. And the third panel shows the tumor, the corneas after the tumor has nicely regressed. Whenever we treat OSSN, we always have to monitor the treatment response with ASOCT. So beneath you can see the ASOCT where it shows that there is hyperreflective epithelium and thickening of the epithelium with abrupt transition. And this, as we give treatment, you can see that on OCT also it is correspondingly decreasing in size. So this is after 2 cycles of treatment, and this is after 3 cycles of treatment where the lesion has completely disappeared. And on ASOCT, you can see that the normal configuration has returned. That's when you confirm that the tumor has completely regressed. Now, again, the use of interferon alpha 2b for OSSN has been extensively studied by our group. And for those of you interested to read more, this is the article that was published in 2016. Now, the other famous drug that is in the market right now is 5-fluorouracil, mainly because the interferon alpha 2b availability has decreased over time. Like many companies have stopped production of interferon alpha 2b, and that is why we have slowly shifted to 5-fluorouracil. Now, 5-fluorouracil is used at as 1% drops, and this we give it as, so the other thing is interferon alpha 2b, we give it continuously. There is no on and off period, unlike the mitomycin C. 5-fluorouracil also has an on and off period. We give the 5-fluorouracil for 1 week, 4 times a day, and then 3 weeks off period. That means they do not put 5-fluorouracil for the next 3 weeks. That's an on and off period. Now, here are few examples where the 5-fluorouracil has completely resolved the lesions. Here is another example where there is extensive lesion that is present, and with just 1 cycle of 5-fluorouracil, the topical medication, it has completely regressed. And sometimes it can be used when the patient is not responding to interferon. Like in this case, the patient has a corneal lesion, if you can appreciate that circular lesion that is present in the center of the cornea. And this patient, we started, he was just not responding to interferon. So we started, this is the corneal lesion that has been outlined, and we started him on 5-FU. And you can see that with just 1 cycle of 5-FU, the lesion completely disappeared. So it can be helpful even in those cases which do not respond to other forms of topical treatment. You can try a different topical treatment and they usually respond. Of course, this is another case where the patient has a tumor recurrence after interferon, and it regressed with interferon initially, and then he developed a recurrence 2 years later, for which we gave 5-FU, and then the lesion nicely regressed. So sometimes you can start the same medication when the patient has tumor recurrence. They respond very well. When they do not respond, you can think of an alternative topical medication. Now, what do you do for such lesions? Now, this is a OSSN again, which is extremely large. We cannot give topical treatment for these patients because it's an invasive tumor. Now, if I want to do exentration, again, it's very difficult because it is almost extending to the cheek. So in this patient, what we tried is systemic chemotherapy. So you can see that with each cycle of chemotherapy, the lesion slowly decreased in size. Now here, the aim was not to salvage the eye because there is no way that we can salvage the eye. But the aim was that at least we can do eyelid sparing orbital exenteration. So the tumor regressed to a size that we could go ahead with eyelid sparing orbital exenteration. Now, these are the lesions which cannot be salvaged. These are the eyes that cannot be salvaged. So whenever there is intraocular extension, we do extended enucleation. What do we mean by extended enucleation is we take 4 millimeters margin around the conjunctiva, and along with it, we remove the eyeball as well. That is extended enucleation. If there is orbital extension, then we do orbital exenteration. Now, next, moving to the last bit, that is the treatment of conjunctival melanoma. Now, melanoma, again, it is treated on the same lines as OSSN, where we take wide margins and do wide excisional biopsy and cryotherapy. If the base is positive, then we do plaque radiotherapy. If there is intraocular extension or extending beyond where excision is not possible, we do extended enucleation. If there is orbital extension, we do orbital exenteration. The lymphoma, we generally treat, this is a case of the orbital and the conjunctival lymphoma. We do external beam radiotherapy if it is limited to the eye. If there is systemic lymphoma as well, then we give systemic chemotherapy. So yeah, with that, I think I have covered the common lesions that we see with the ocular surface tumors. So now I'll be happy to take any questions or any comments that anybody has.
Thank you very much, Dr. Swati. Any of our panelists would like to discuss something? Ruma ma'am? Ruma ma'am, are you there? Is Dr. Sahil?
She's there. I think she's muted. Yeah. Unmute yourself. Yeah.
Yes.
Ruma ma'am, would you like to say something, ma'am?
There is
Dr.
one stain for OSSN which can be used to diagnose. Can anybody tell what is that stain which we use?
Rose Bengal stain.
Rose Bengal stain.
Rose Bengal stain.
Okay, what is that stain? What is the type of stain? What type of tissue does it stain basically? And how does it
Devitalized tissue.
Devitalized tissue.
Okay, so why we are wanting devitalized tissue?
To know the margins of the tumor which is not visible.
So which type of tissue is that?
Dead necrotic.
Those are keratins mostly. So those are dead tissues which can be differentiated within the normal tissues. And what else can you do in that? If you are suspecting a early OSSN which you are not able to diagnose, then how do you diagnose it? What type of investigation or a procedure you will do where you can diagnose it without excision?
Patient cytology we can do, sir.
Okay. Any other thing?
We can go for anterior segment OCT.
ASOCT, sir.
Okay, that is good. Non-invasive. And following treatment, once you go for excision biopsy and still you think that there may be some residual one following treatment with topical therapy also, then what else you do for confirmation that it is clear? Something with the cellulose acetate paper.
Impression cytology.
Yeah. You're saying it. Say it loud.
Yeah, that's right.
With
So these are some of the options which we have.
Patient cytology.
Yeah. Okay. Then can I send the screen actually? I want to share one photograph which may mimic your papilloma. Okay. I'm just sharing it. 1 second. So anybody knows what is typical about Western Orissa, something special found in that?
In what, sir? In OSSN?
Yeah, not OSSN exactly. It's not a tumor, surface tumor. It's basically,
Ocular rhinosporoides.
yeah. Anybody seen that? I think it's
Yes, sir.
abundant.
We see them daily, sir.
Yeah. So that is actually regional. We get very less because whenever I talk in the forum or somewhere, hardly anybody knows like what it is because they're not exposed to in their clinical practice. So it is also a differential which comes as a papilloma with studded sporangias and other things. So we have to know that also. Sometimes patient present with that. So the treatment is mostly excision of the lesion only. That is the only treatment, and it's very easy to do. One thing is that we have to diagnose it properly. I think this is the one.
Hello.
Can anybody see it?
Yeah, we can see the picture, Dr.
So
Meher.
what else? What else is there? The main lesion is here, as you see. This is thinned out staphyloma. Is in the superior limbus area, and this is the lesion which is covering it. So this is a long-standing case, of course. Patient presented to us with blurred vision, of course, and there is a mass over the superior part, just underneath the lid. So he presented like that. Then when we saw it lifting the lid, then we saw a big staphyloma. There is a thinning of the sclera. So the only treatment for this type of case is we did an excision of the rhinosporoides along with the betadine cautery, along with the cautery of the surrounding area. And we did nothing for the staphyloma because usually the cause for the staphyloma is the rhinosporoides itself. So it's not required to do any staphylectomy or do any patch graft or any Tenon's graft. And of course, the staphyloma will not resolve by itself or undergo complete flattening, but still, because the vision was 20/20 or 6/6, so we didn't want to go for any involvement or any intervention for this staphyloma. So these are some of the cases we have to know exactly that there is a rhinosporoides which may occur. So it's very typical white studded sporangias which are available on the surface. So this I want to just highlight.
Hello, Dr. Swati.
Yes.
I'm audible. Yeah, Dr. Pombi from Bhagalpur. I have only 2-3 questions from you. Simple doubts. How will you differentiate corneal OSS, the faint corneal OSSN? Because that faint OSS we can miss. So the only thing you have told that fimbriated margin, the other things we can look for so that we can't miss the early corneal OSSN.
Yeah, I think I think first of all, I really want to appreciate the picture shared by Dr. Meher. Very interesting picture. Very, it just catches your eye. Thank you for sharing that. About the corneal OSSN, very relevant question because I think this is something that might be missed, as you already mentioned. So there are two features that we describe. Of course, one is fimbriated margins, and the second is heaped up margins. That means it will have like a lining of the margin, like in one of the picture, if you remember, it was the tongue shaped which was there. It will be like thicker at the margin. So that is what we call as heaped up margin. The other way, of course, retroillumination, which I've already discussed, and the best way to outline the corneal lesion is by rose Bengal staining, or even if you don't have rose Bengal staining, even fluorescein stain can outline it. But the objective way of knowing the corneal OSSN is by ASOCT. So by ASOCT, you will see that generally the corneal epithelium, if it is normal, it is hyporeflective. But if there is OSSN, it will become hyperreflective. Hyperreflective with slight thickening of the corneal epithelium as well. So the objective way is always by ASOCT. So when in doubt, just do an ASOCT and that will help you to differentiate if it is say corneal opacity or its corneal OSSN, that's very helpful.
Thanks, Swati. And the second is how many cycles we can try 5-fluorouracil? Means 1 week on, 3 weeks off. Then how many cycles we can try?
Yeah. So that again, I think is a very, very practical question. So generally, when we say treatment failure, we call it as treatment failure or non-responders if they do not respond to treatment after 3 cycles. If after 1 cycle, if there is no response, the patient comes the second time, if there is no response, then it doesn't mean that you switch to a different topical medication. No, that's not necessary, because sometimes the patient may not show response with 1 cycle. So we call it as non-responder only if they do not show any kind of response after 3 cycles. If that happens, then we have to think of alternative treatment, which can be in the form of alternative medical management or go ahead with surgery. Now, I think for all of you who are listening to this also, please understand that topical treatment is not for every case of OSS, and that has to be very clearly understood. Topical treatment helps only if it is non-invasive. That means if it is not extending deeper into the stroma, only then it is helpful. If it is invasive squamous cell carcinoma, then the topical medication is not going to help. How do you know if it is invasive or not? Simple test that tells you whether it is invasive or not is in the clinic. If you can just put a cotton bud next to the lesion, move the conjunctiva. If the conjunctiva is moving freely, that means it is not invading deeper. If the conjunctiva is stuck, then that means it's like, no, it is invading deeper tissue, and the topical medication may not completely solve the problem. It can reduce the non-invasive component, but not completely erase it. And one other important practical point that I want to add here is that once the tumor regresses, please don't stop the medication immediately. We always give 1 extra cycle, what we call as consolidation treatment. So if, say, for example, with 3 cycles, the tumor has regressed, then when the patient comes back to you, there is no tumor, you give 1 more cycle after that. So that means 1 extra cycle of IFU is what we, at least what I personally would recommend.
Thanks, Swati. One more little question, small question. How important is impression cytology in OSSN?
Yeah, so impression cytology, in my experience and what I believe, is more of a historical interest rather than like, a practical thing that is with the availability of ASOCT and all of it. It was probably more useful in the era when ASOCT was not there. Where we didn't know how to diagnose OSSN, but now with the availability of ASOCT, that is more objective way of diagnosing OSSN. So in the past 10 years, I have not done a single case of impression cytology.
Nice, thank you. Thank you, Swati.
Yeah.
Dr. Swati,
ma'am, please go ahead.
Dr. Sahil, you want to ask something?
No, ma'am, please go ahead.
Dr. Swati, I want to know about certain novel therapies. I have read in your article on OSSN about the novel therapies. Would you like to say something on it?
Yeah, so there are various other topical medications that are being tried, like, even vitamin A has shown benefit. Cidofovir is one drops that has been tried and shown benefit. Anti-VEGF has been tried, and few reports are there where anti-VEGF has helped. Laser photocoagulation has been tried. PDT has been tried. There's a photodynamic therapy. So there are like, a lot of medications that have been tried and shown that, okay, there is benefit. But most of these reports, we don't have a long-term outcome. So I do not have a personal experience on these techniques as well, because we have not used these. So it's hard for me to comment whether these are this will act in all cases or not. But yes, there are isolated case reports that have been published by different groups where they have shown the different other medications that can be used. But in my experience, I would say that the topical medications, be it interferon or 5FU, 95 to 98% of the cases respond very well. And it's like, when I think 5 years before, I used to do a lot of surgeries for OSSN. But now with all these topical medications being so effective, not many surgeries have to be done. Most of them can be handled with topical treatment. But yes, one common problem I always encounter is people are abusing these topical medication. For every case of OSSN, they just start the patient on topical medication, which I think for all the postgraduates, I want to make it clear. It's not that every case can be treated with topical medication. You have to choose the treatment wisely. If it is invasive, then topical medication is not going to help. Surgery is the option for invasive OSSN.
Thank you so much. Dr. Sahil, over to you, please.
Hi, ma'am. So, in cases of, ma'am, post-septal extension of OSSNs, do you try systemic chemotherapies, smaller down the tumors and then go ahead with an extended enucleation? Or do you still prefer exenteration over doing a systemic chemotherapy with an extended enucleation?
Yeah, I think it depends upon what is the visual potential as well. Like say, for example, if the patient is just having a tumor, say in the fornix extending into the orbit, but has 20/20 vision, then I would still want to salvage that eye. So I would try to do everything possible to salvage that eye, which can be, I know that there have been isolated reports of even using interferon injection for the orbital extension of the tumor and showing that the eye can be salvaged. So it truly depends upon the visual potential. If it is something that there is chance that we can save the eye, I would want to try to save the eye first by doing systemic chemotherapy, whatever, the medication that we can use to save the eye, but not at the cost of it harming the patient. If it is not responding, I would not push it too much. I would just explain to the patient that it is best that we just remove that eye and go ahead with exent or enuc, depending upon the extent of the lesion.
Ma'am, are there any specific biomarkers that are under investigation, telling us about the high-risk cases that might recur, anything as such?
So we tried a couple of years back. In fact, we tried to look at what are the features that might predict the tumor recurrence, but we couldn't identify very specific features. So at this point of time, I would say from my experience that we cannot pinpoint and say these are the ones. But yes, but in general, I think the lesions which are in the tarsal conjunctiva, they tend to recur more often because whatever drugs you use, it's very difficult to retain there and treat those lesions. So I think those lesions tend to recur. But otherwise, no specific features as such at this point of time.
Thank you, ma'am.
Thanks, Sahil. It's good to see you.
Same here, ma'am.
Anyone else?
Yeah,
Residents, do you have any questions? Yeah.
One question. Is there any specific protocol should we follow in xeroderma pigmentosa? Because one of our patients has xeroderma pigmentosa present with severe OSSN, all the ocular tissues, including the fornix and orbitus involved. Yeah. In that patient, spatial treatment or spatial measure should we take? Because the exenteration also not visible because it will not heal. It will ultimately culminate into an abscess or some sort of complication, further complication.
Yeah. Thanks, Manu, right? Yeah, Manu, for the question. Yeah, I think xeroderma pigmentosum are very difficult patients to treat. In fact, of course, in some of the publications, they have recommended lifelong prophylaxis for them once you treat with topical medications. The lifelong prophylaxis, at least that was recommended at that time, was interferon, because interferon is very safe to use. Long term, you can keep using it. But I will not be comfortable saying the same thing with other topical medications like 5-FU or mitomycin C, because they will induce complications. So for these cases, I think I would say that the follow-up is what is really, really important, like a close follow-up, like increase the interval between each follow-up, I think has to be short. They should not be treated as other cases of OSSN where generally we might see once in 3 months for a routine follow-up. These cases have to be seen more frequently with decreased interval between the follow-ups and handle the lesions as they are small rather than let them advance that it reaches the stage of ENIOC or EXEN. But yes, I completely agree that these are very, very difficult cases to manage, in spite of the patients being very regular to follow up and us following all protocols. Sometimes they might end up with losing an eye, unfortunately.
Unfortunately, at the cost of their life also. I don't know if patient is alive or not.
Yeah.
Thank you.
Yeah, dear students, any questions or any doubts?
Ma'am, how do we diagnose clinically amelanotic melanoma, ma'am? The amelanotic type?
Yeah. Okay. So as I mentioned, yes, I think first of all, you asking me this question gives me confidence that that amelanotic melanoma can occur. So these lesions, when the amelanotic melanoma also, it's not that they're completely devoid of pigment. It's just that they will have some pigment dusting that might be present at the margins. So generally, how do we differentiate? So it will be like a fleshy mass that would be present on the ocular surface. The way we differentiate a amelanotic melanoma from OSSN would be that OSSN would have some amount of keratin, especially if it is a large nodular area, while amelanotic melanoma will not have any keratin, but it will just be a fleshy area that might be present. And most of the times it might be that there is a pigmented portion of melanoma and there will be a amelanotic portion, or there might be an underlying PAM that might be present. So that's how you differentiate or you identify that it is amelanotic melanoma. But either ways, whenever it is malignant, the treatment principle remains the same. Whether it is OSSN or pigmented melanoma or amelanotic melanoma, the principles of treatment of wide excision biopsy with 4 millimeters margin remains the same.
Thank you, Dr. Swati. Anyone else?
So
Yes.
I think let us close.
Yes, sir.
Any comments from anybody? Dr. Pranabji, Dr. Jayant Baraji, and Dr. Ajit Babu. Before we ask our
We had a
Rahul
session for the residents, but also for us.
Yes, sir.
Thank you, Dr. Pranav. So, yeah, I mean, I think I would just like to extend sincere thanks to all of you for giving me this opportunity to interact with the postgraduates. Thanks a lot.
It's a really wonderful lecture. I think before I offer the prayer, vote of thanks, I request Mr. Rahul. Rahulji, are you on there? Rahul?
Not there, I think. You told him to prepare the video, but
Yeah, but
it's all right.
it's 9:20. I must be expected it to go over by 9:30. So that's why. Rahul, are you there? Yeah, so
he's there, but he's gone to sleep.
So let me offer the vote of thanks on behalf of the EIZOC ORTS program. So thank you, Dr. Swati. I think it's a really wonderful lecture and so clear and so many explained with a lot of pictures. Normally don't see, and really wonderful lecture. Thank you very much for joining with us today, and probably we look forward to meet you once again. And I thank our moderator, Dr. Sarmishta, bringing out the best out of all the panelists. I thank the panelists also and the students. Yes, today a lot of students have asked a lot of questions. And I think really so encouraging for all of us, for the organizers to organize similar programs in the future too. I thank everybody. I thank Dr. Jayant Baraji. I welcome you again. So now you will be the president of EIZOC, sir. Yeah, you'll be taking over from Kalimpong. I welcome you. So thank you, Dr. Baraji, joining with us today. So At last, but not the least, is our the platform provider, the Enter Pharmaceuticals. Rahul, are you there? Yes, Rahul is there.
Started, yes.
Okay, thank you. Rahul, continue. Okay, thank you all. Good night.
Thank you.
We will see
Good
you
night.
next month.
Night. Good night.
Good night.
Yes, sir.
Thank you,
Good
Swati,
night, everybody.
for accepting.
Good
Thank
night,
you, everyone.
Swati.
Good night.
Really, it's wonderful lecture. Enjoy.
Thank you.
No.
Thank you. Bye.
Good night.
Good night, sir. Thank you.
Good night. Good night, everybody.